That would be embarrassing if I had everything else going. Okay. So the format that I have for you guys, I kind of try to hit a high level of everything. All right. If that's too much, I've kind of prioritized it to some things that you're going to need to know as nurses, in my mind, first. Well, you kind of need to know all of it, but maybe some of the things that are a little bit more confusing, I'm going to go ahead and hit first, okay? If we don't get through all of it, we don't get through all of it. I also have some Kahoots that we can do. Are you guys familiar with Kahoots? Mm-hmm. Okay, so you guys are all good there. Yay. Okay. So Fun with Pharm, why are we doing this? It's not just because we're having fun. I know this is what you guys do on Friday nights. So our pharmacological therapies make up to, ready? Roughly 15% of your exam. Could be as much as 18, as little as 12, probably depending on whether or not you get that first question right? You will also use them in clinical practice. Why else is it important? Patient safety, we prefer not kill them, right? Things like that. Even if you're not an inpatient nurse and this isn't what you want to be doing all the time, you don't want to be ICU nurse, that's cool, but you're going to still see pharm no matter what you do. You know what I mean? If you're a home health nurse, oh, absolutely. Even a school nurse, going to see it. Going to see it often, okay? From what I understand, NCLEX tests you on what they would expect the basic new nurse in roughly like a med-surg position to know. So certain specialties, the oncology nursing, you might not need to know quite as well. You might want to know a few details, but if you're going to be like Anne-Marie, that's really a specialty area, okay, that they'll teach you a little bit more. You're not expected to know everything about chemotherapy when you go into the NCLEX, okay? So what kind of format are we going to do? We're reviewing some of the more commonly used drug classes. I'm not going to talk about myasthenia gravis because even if you might see it later, it's not the biggest thing that you're going to see. Okay? It's designed just to kind of get the memory going again, get those basic things that you may or may not remember from 2 semesters ago. Certainly not comprehensive. I have a whole presentation on practice questions, or we could just do Kahoots. Students find Kahoots more fun. I say let's go that way. Audience participation is recommended and encouraged. I threw out candy. Why? I try to hit the person that's sleeping. No, it's because, as you guys, most of you know, how many of you have had me? Yeah, I'm an introvert. So my daughter raises her hand. There's my Elizabeth. I'm an introvert. Standing in front of people to me is very, very difficult. So I want you guys to have to speak up too, okay? All right. Yeah, otherwise you have to keep hearing me. Let's go. Okay, let's start with our ACEs. Do you guys remember ACE inhibitors?
Yes.
All right, what are they used for? Hypertension. That was you, right? Yeah. Okay, now, other disclaimer, I played first base, not third base. What does that mean? First base, that means I'm great at catching it. I am hideous at throwing it. I do not have an arm, so it's going to get ugly. All right, so we use it for hypertension. It's also prescribed for heart failure sometimes. Following MI, we could either lower the risk of an MI, lower the risk of a CVA, or help protect following MI. Okay? So, do you guys remember? It's going to relax the arteries. Just remembered one slide's going to drop. It's going to increase the renal secretion of sodium and water. And remember, sodium's the cool kid. Wherever sodium goes, water wants to follow, okay? It's going to decrease our blood pressure. The one in red is the important one. That's what you need to remember. In doing so, it's going to decrease the cardiac workload a little bit, all right? So, you're part of the program. What are some potential side effects of our ACE inhibitors?
Dry cough.
Dry cough. Awesome. Everybody make sure you know that. That dry, annoying cough. Doesn't necessarily mean they're going into anaphylactic. No. No, it means they have a really dry cough. If they get over it, they get over it. If they don't, we're going to change them to their sister. The sister is an R. Larry. Hyperkalemia, right. We are sparing some potassium, so we could see some hyperkalemia. Or the static hypotension. You got it. Big time. Angioedema. Certain ethnicities are going to be more prone to angioedema than others. Do we have any more back here, or do we take them all out? There'll be more questions. That's good. All right. So angioedema we could see. If somebody has anaphylactic angioedema type reaction to one ACE, they're going to all the other ACEs as well. It's off the table. My notes. ACE inhibitors are one of the most frequently tested antihypertensive drugs on NURS. They don't increase the cardiac output necessarily. They don't increase the rate or the contractility. Oh, there you go. Watch your renal function as well. Okay? If we start to get with an elevated creatinine and an elevated BUN, if we start to see our eGFR starting to fall into the 40s, going to have to go ahead and hold it. All right, sister drug, or the pretty cousin, who's a little bit more expensive, is our ARBs. Now, our ACEs all ended in what? Krill. Awesome. Our ARBs end in what? Sartan. Sounds like, I don't know, where else it doesn't. Maybe just a Greek thing. Okay. ACEs and ARBs. Now, we don't technically use pregnancy categories anymore, which makes me so sad. But if we did, what pregnancy category is our ACEs and ARBs? X. Bad. Okay. It can cause fetal harm. So if you have a woman, childbearing age, with hypertension, do you want her on ACEs and ARBs? No. Choose something else. We've got enough to choose from. All right. Again, it's going to allow the blood vessels to dilate. It's going to decrease our blood pressure, which it's supposed to do. Decrease the cardiac workload a little bit. Again, very, very similar indications. Hypertension, heart failure, kidney failure and diabetes. This might be a little bit nicer to our kidneys than our ARBs, but not tremendously. If we have that really, really dry, annoying cough that we had with our ACEs, try an ARB. Not as likely to have a dry, annoying cough. All right. We're going to have very, very similar side effects with our ARBs as we did with our ACEs. All right. Anybody? My back corner didn't get any. Orthostatic hypotension. Awesome. Yep.
Vomiting.
Nausea, vomiting. You can say that for every single one of them, though. It doesn't matter. Tylenol will make you nausea, vomiting. Don't memorize that necessarily. What else? What happens to potassium? Increases. I saw him. He didn't talk, but I saw it. Okay, he doesn't eat sugar. Just kidding.
Thanks.
All right, so I just broke her bowl. Okay. Here's an error. Again, we might still have to watch for angioedema. The big ones to know is know what it's doing to your potassium, especially if we're giving it with other medications that can also increase our potassium. Hopefully it'll still catch us, okay? Beta blockers. Do you guys remember beta blockers? They ended what? LOL. I love beta blockers. They make me happy. Look at how small that print is. That's like an eye chart for you guys back there. So let me help by reading. What does it do? It decreases the blood pressure. What else does it do that our ACEs and ARBs do not do? Decreases the heart rate. Absolutely. And that's kind of important. In doing so, it also decreases the cardiac workload. It decreases the myocardial oxygen consumption. Does that make sense? We're all good there? Okay. So we use it for hypertension. We use it for MI. So have you guys heard MONA, M-O-N-A? If somebody's having an active MI, MONA has a last name and it begins with B, beta blocker. Okay. We can use it for angina. Not so much in that it's dilating the coronary arteries, maybe a little bit, but not really. What it's doing more importantly is decreasing the cardiac workload. Okay. We can also use it for some dysrhythmias, particularly the tachydysrhythmias, preferably those that start in the atrium because it's decreasing the overall heart rate. Very mild to moderate heart failure, we will use beta blockers. If we have severe heart failure, a beta blocker will make it worse. Does that make sense? Okay, do you guys remember hearing that at all? Kind of ish. So mild heart failure, we can still use it. Severe heart failure, we probably don't want to, okay? This is also going to slow down the conduction a little bit from the SA node through the AV node, okay? So if we have an AV block, if it's a second or third degree, we probably don't want to use it, okay? What are your big side effects, as I try not to break the bone? Bradycardia. Bradycardia. You guys are faster than me. Hypotension, here, catch. Orthostatic hypotension. When in doubt, always say orthostatic hypotension. Anybody else? Yeah. Yeah. She's like, I don't know. I just want Skittles. Okay. So we might also see dizziness. That's a possibility. Nausea, vomiting, sure. Worsening heart failure, right? So what are signs and symptoms of heart failure? Edema. Let's start. Pulmonary edema, especially if we are left-sided heart failure. If we're right-sided, we're going to see peripheral edema, right? Okay. What else? Crackles. Crackles usually starting at the bases, right? And then they're working their way up. Why do they start in the bases? Gravity. It's just gravity. Wheezing. Okay, so now, how many types of beta receptors do we have? Just give it away. Two primary ones, okay? Beta 1 affects what? Beta 2 affects? Awesome. Some of our beta blockers are non-selective, meaning that they will affect both our beta 1 and our beta 2 receptors. If we have a non-selective beta blocker, we could get wheezing. We could also mask the signs and symptoms of hypoglycemia. So if you have a patient with asthma or COPD or diabetes, you may wish to choose to have them use a beta 1 selective beta blocker. Does that make sense? Because then hopefully you're only acting on the beta 1 receptors and blocking those, okay? Hopefully then you will have less issues with wheezing COPD. It's not a complete contraindication, we just have to be cautious. And with our patients with diabetes, we're going to tell them, monitor your blood sugar more frequently, just in case, all right? So, do you guys remember those? I liked those. All right. Our calcium channel blockers, they do a bunch of things. Some of them decrease cardiac contractility, okay? And the two that work on your heart are verapamil and diltiazem, okay? Anne-Marie told me that the best way to remember that is the two that affect your heart, and with VD standing for Valentine's Day, think of heart, okay? They're going to, those two and those two only will decrease the heart rate. All of them will decrease the blood pressures, okay? Decreasing the cardiac workload and the myocardial assumption. Other than verapamil and diltiazem, the rest of them end in dipines, okay? The dipines do not function as well on the heart. They only function more on the blood vessels, okay? So you can also remember very nice drugs. Nifedipine is what they're thinking of there for your calcium channel blockers, okay? I would ask for side effects, but it's kind of right there. What are some side effects? Hypotension. Hypotension, of course. If it works too well, that could be an adverse effect, right? What else? Headaches. Headache. Possibility. What else? It's quiet over there.
Bradycardia.
Bradycardia if you're using your verapamil or your diltiazem. Not so much if you're just using the dipines, okay? The big one that you need to watch for is peripheral edema. And for the ones that work on the heart, we have to watch again for AV blocker, slowing it down a smidge, okay? We could see worsening of heart failure if we're using verapamil or diltiazem simply because of the effects on the heart. So if your patient has heart failure, we're using with a little bit of caution. Cardiac glycosides, the only one that we really have that we're utilizing is going to be digoxin. Okay. When my mom was a nursing student, there was 1 million questions on dig on her boards. When I was a nursing student, there was only 500,000 questions on dig on my boards. I'm hoping that there's only going to be 250,000 of them for you. It's not first line, it's not second line, it's kind of third line, but because there's specifics and because there's interactions and because there's therapeutic indexes, because there's things that they can test you on, you might still see it. I'm hoping not, but it's been 12 years since I took it. So what does it do? Digoxin is kind of neat because where other ones slow down the heart and decrease the contractility a smidge, digoxin can slow down the heart but yet increase the contractility. Does that make sense? So it's slowing down conduction through that AV node, but it actually increases the contractility. Positive inotrope. Does that sound vaguely familiar? All right. So it can be used for supraventricular dysrhythmias. Remember, supraventricular dysrhythmias is a fancy way of saying dysrhythmias that originate in the atria, okay, such as AFib, A-flutter, maybe SVT. It's not first line anymore. More likely, you might see it in heart failure. In heart failure, where it's really quite severe, where we need to go ahead and increase the squeeze of the heart, right? We've got some significant cardiomyopathy. We've got that big floppy heart that's not functioning tremendously well. Do you guys remember side effects of digoxin? Come on, it's been a while.
Like halos.
Who said, yeah, visual disturbances. Anytime you see the word visual disturbances or halos or green, yellow, think potential dig toxicity. Yeah.
Bradycardia.
Bradycardia, yes. What do we have to do nursing intervention-wise before we give digoxin? It has to be actually apical heart rate for a full minute. Okay. Important to note, anything that can fix a dysrhythmia can also cause a dysrhythmia. Okay. So since dig can be used to fix dysrhythmias, heads up, it can also kind of cause them. So we just want to use a little bit of caution. The other really important thing, monitor your potassium level, okay? If your potassium level is too high, your digoxin isn't going to be very effective. If your potassium level is too low, your digoxin level can get too elevated. We can have toxic effects, increased risk of dysrhythmias, including those that are fatal. Does anybody remember your therapeutic index for digoxin? He said 0.8 to 2. I have 0.5 to 2.0. The book that we used, we changed the book next semester, sorry. But ours was very, very specific, and I think it even had a more narrow range. I believe NCLEX still uses 0.5 to 2.0. Okay. And typically, they're not going to say something like 2.1 or 1.9. They're going to make it pretty obvious if they really mean that something's out of there. So the other one for dig toxicity, anorexia. They're not eating. They don't feel good. Our antidysrhythmics, I love those. I probably hounded you for years on those. The thing of it is I don't know that you necessarily need to know all of them for NCLEX or HESI, simply because that's where we're starting to get a little too specialized. Okay, so what they do is they delay the cardiac conduction. Okay, there's 5 different types, and you don't need to know them necessarily. But here's the important thing to know: they are given only when it's clinically significant. Okay, if that dysrhythmia is causing an issue, then we go ahead and administer an antidysrhythmic. Back in the 80s, when my mother was an ICU nurse, somebody would have a couple of PVCs and they'd throw them on a lidocaine drip right then and there. Okay, they did some studies in the late 80s and they realized they were actually doing more harm than good by putting everybody on lidocaine drips. They actually ended up creating more dysrhythmias, again, some of which are lethal. Okay? So if you have a couple of PVCs, not really exciting. We all have PVCs probably because you're tired and are drinking too much caffeine, right? We're not going to do anything. All right. Usually when we initiate antidysrhythmics, we need some EKG monitoring, okay? And all of our IV push medications specific for cardiac are given slowly, right? What's the one exception to that? What? Atropine. Atropine are still going to give kind of slow. How about adenosine? Do you guys remember adenosine? Yeah. I love adenosine. That's my favorite. Okay. And again, there's 5 different classes of antidysrhythmics. I don't think you need to. Okay. Drugs for angina. You guys holding up okay so far?
Yeah.
Okay. Let me see if I have any cahoots in there that we want to break with. Were there any good cahoots? I think some of them I've made for my farm class, and I think some of them are too specific for you right now. Nope, this will be our first Kahoot then. Okay. So, nitrates, nitroglycerin. Does that sound familiar? Okay. So, what do? They relax the smooth muscle. They vasodilate, okay? In doing so, they're going to decrease the blood pressure. They will also decrease the cardiac workload, decrease the myocardial consumption. Okay, oxygen consumption, which is important, right? Nitrates, that's one of the things in our Mona B, right? One of the things that we do. So if somebody's coming in with an acute MI, we're going to go ahead and give morphine, oxygen, nitroglycerin, chew an aspirin, and a little bit later we'll throw on a beta blocker. Okay? So they can be used for angina, either unstable or stable angina. Again, obviously for an MI. They can also be used for hypertension. What are some side effects?
Oh, headache.
Headache. Oh, headache's that huge one. That's the one you should know. Headache, 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 always. Your patient's going to get a raging headache. But don't worry, you're making them chew an aspirin, so it's okay. All right.
Flushing.
Flushing. Good. They're good. We might get a little bit of hypotension. All right. We might get a little bit of reflex tachycardia because anytime that we decrease the blood pressure but we don't slow down the heart's going to try to compensate for our cardiac output by increasing the heart rate a little bit. Okay? We will definitely see that with our calcium channel blockers, the dipine group. Okay? For nitroglycerin, we have short-acting versus long-acting. Does this sound vaguely familiar? So our short-acting is like our spray, our sublingual, okay? Do you guys know why do we give things sublingual?
That's immediate.
Immediate. What else do we avoid? First pass effect. Awesome. Good job. Wait. Are we still sugaring up here? All right. We avoid the first pass effect. First pass effect we're only going to get if we give a medication orally. If we want to avoid it, we're going to give it any other route, right? We can give it topically, rectally, sublingually, IV, IM, you name it, all right? Now, short-acting is used for acute unstable angina and MI, okay? We also have our long-acting formulas, and those are either in tablets or more often you'll see it in patches. Have you guys seen nitroglycerin patches? Those are usually used on for 12, off for 12, okay? The reason for that is that nitroglycerin builds a rapid tolerance. Unless you use them and give a break, they will no longer be effective. Same as like our lidoderm patches for pain management. That's why they're on for 12, off for 12. If you keep them on all the time, you're going to build a tolerance and it's not going to be effective, right? Okay. What else do we need to know there? Done. Do you guys want a Kahoot? All right. Let me load up my Kahoots real quick. And you guys can load up your apps as well. Okay, here we go. There we go. I think this one only has 3 questions, maybe 4. 3 questions. It's pretty easy. Here we go. We're going to do 1-to-1. And our pin is going to be 56327. Again, 3 questions, hopefully not too bad. Who's Carl? Carl? All right. And Wolfie. All right. Okay, me too. You want to play too many times? That's good. Okay. Everybody in that's going to be in? Okay. I don't hear music. Do you guys want the annoying music?
Yes.
No. All right. Larry said yes. We'll do the music next time.
I won't work with the camera.
Oh, maybe not. Okay. So you teach your patient with angina about sublingual nitroglycerin. Which one shows understanding? Is it going to be A, I experience headache as a side effect? B, chest pain should be relieved within 20 minutes. Yellow, I should swallow the tablet and drink a glass of water. Green, I should take the medication in the morning before breakfast. Extra points for speed here, guys. All right, correct answer is headache as side effect. Blue is not correct. How long should it take? 5 minutes. If you do not have relief within 5 minutes, what do? Take another one now. It's probably also time to start dialing 911. If you don't get relief within 5 more minutes, what do? One more. 3 strikes, we're done, although theoretically they'll probably give you a couple more on the ambulance ride over. Sublingual, should it be swallowed?
No.
Are they taking it in the morning before breakfast?
No.
No, this is my short-acting one. My short-acting is PRN only, okay? All right, next. So far, so good. Way to go, Laura. And Carl, the janitor, is right behind. All right. So we have nitroglycerin transdermal patch, long-acting, short-acting? Long-acting. All right, so what do we want to do? Oh, can you not read?
No.
Okay, red is apply the patch to the chest over the heart. Blue is change the patch each week. Yellow is remove the patch at bedtime. Green is put on the patch before exercising. All right, we want to remove the patch at bedtime. Long-acting, we could build a rapid tolerance. It's not once a week. It doesn't need to go over the heart, and it's not PRN. Okay, this is long-acting every day. Last but not least, Laura's still rocking it. You're educating your patient about sustained release nitroglycerin for chronic stable angina. What do you want to say? Red is avoid exercising to help prevent chest pain. Blue is place the capsule under the tongue if chest pain occurs. Yellow is take the capsule as needed before exercise or exertion, or green, sit or lie down if dizziness or lightheadedness occurs. All right, so we don't want to tell our patients to avoid exercise. They need to exercise. Under the tongue is not going to be an extended release, right? That's our immediate release. And we don't want to take it only as needed. These are long acting. Go on. Oh, Carl, Maggie, and JC. All right. Carl. He doesn't eat candy. Where's Maggie? Who got silver? All right, way to go, Maggie. And who got bronze? All right. Don't make me throw that part. No. All right. We'll keep going here. Okay. Okay, so as we said, we have our quick-acting nitroglycerin, again, PRN. Long-acting are slow, which is going to be on 12, off 12, okay? All right, diuretics. I love diuretics. We're going to be learning about this week. Every single time I've ever done this presentation, I said ignore the first two red bullets because obviously I copied and pasted. Look, I even have in my notes, change this. Hasn't happened yet, sorry. Ignore that, ignore that. So what do? For the most part, they remove water. For the most part, they remove sodium. How do they do so? They do so in slightly different mechanisms. But the first three help to pull off some sodium. And then again, sodium's the cool kid on the block. Wherever sodium's going, water's going to follow. Okay? Again, they do nothing to your cardiac contractility, and they do nothing to your conduction through your AV node. Go ahead and delete that, and maybe I will actually make that change when I'm thinking about it.
It's right on ours.
It's
right on ours.
Oh, see, there was some thought process there. Used for lots of reasons, right? Name some reasons that we're going to go ahead and give diuretics. Heart failure, awesome. All right, you guys are quiet over there. Hyperkalemia, only some of them. Pulmonary edema, definitely. Hypertension, absolutely. We love our thyroid diuretics.
Increased ICP.
Increased ICP, and which one are we going to use for that? Mannitol, only our osmotic, and that's the only one that we're doing. What about it? Anything else? Okay. Okay, so what happens to our potassium with our loop and thiazide diuretics? It's going to decrease, sometimes significantly, so make sure you're monitoring your electrolytes. Our sodium will also decrease with those, okay? Which one is the best diuretic if I have a patient with CHF, fluid overload, crackles halfway or all the way up? Which one am I going to give? Loop diuretic, typically IV push. Should start to kick in within about 5 minutes, okay? Loop diuretic, even if you don't have great kidney function, still going to work. Thiazide diuretic, not so much. You need normal functioning kidneys for your thiazide diuretics to work, okay? Your loop diuretics end in stamide or tanide. So furosemide, metonide, okay? Thiazide diuretics end in thiazide. Oh, I love that. At least it makes it easy for you. So thiazide, hydrochlorothiazide. Our potassium-sparing diuretics, are those actually really good diuretics? No. Nah, not really. Actually, might get a little modest diuresis, but not tons more than that. Why do we give potassium-sparing diuretics? We want to increase our potassium. You're right. There's going to be some times when we're actually going to give it with a loop diuretic just to help balance out. Does that make sense? So with our potassium-sparing diuretics, if we're also giving an ACE or an ARB, what do we want to watch for?
Hyperkalemia.
Hyperkalemia. Awesome, big time. And our osmotic, the only one we have is mannitol, okay? That one does not necessarily pull off our sodium, by the way. That one actually retains our sodium. And the only reason that we're giving mannitol, our osmotic diuretic, is for increased intracranial pressure. 99% of the time, that's the only time we give it. Sometimes we could give it to get toxins out of the body, but very, very rarely. Okay.
I could do that with chemotherapy a lot. There's one chemo we always give away.
Yeah, but all right.
You don't need to.
Fair enough. Fair enough. It can remove toxins from the body,
Yeah.
but otherwise, it's because you probably have had a trauma. Yes.
I had a patient who told me he was on Lasix and it actually made him retain water. And I had to tell him how confused he was about that because that's the exact opposite. And he started arguing with me, and I was like, you just pick your battles on that one.
And then when you just go, is that right? I mean, what are you going to say?
It made me retain so much water, and I was like, I think they gave it to you to stop that.
Those are the same patients that say they don't want to take insulin because, it gives them diabetes.
Yeah.
All right, fair enough. So, let's see. According to this, NCLEX still likes our diuretics. Okay, so FYI. Oh, yeah. Other side effects are going to be, we are going to decrease the blood pressure a little bit, are we not?
Yeah.
We could decrease the volume. That's the whole point. So we could get a little bit of dehydration. With most of them, we will decrease the sodium, mannitol being the only one that's the alcohol there. Okay. So in addition to potassium, please monitor your sodium and other electrolytes. Vasopressors, I'm going to use a phrase that will give you all PTSD. These are our adrenergic agonists. Sorry. What do they do? Otherwise, we call them pressors, right? Vasopressors. And again, now we're starting to get a little specific into Amy's ICU land, so she loves it. But what does it do? We're going to use it when your patient is in shock, usually, when they're severely hypotensive, okay? How many of you are doing your capstone right now? Wow, holy cow. Where are you mostly doing your capstones in? Where are we settling out? ICU, ER, med-surg, ER. Okay, so a lot of you then maybe, you may or may not see this. So what does it do? It's going to increase the blood pressure. It's going to increase the heart rate, usually. It's going to increase the stroke volume, increase the cardiac output. It's going to do what we want it to do. Also think of epinephrine, EpiPen. We can also use this for anaphylactic shock, right? Big thing to remember. Your patient uses their EpiPen. Is that it? They're done? They're good? No. We could have rebound. Please go to the ER at that point, okay? These are also our code medications. We're going to push epi and atropine in the event that somebody is coding, okay? Again, used for hypotension. We want to administer via a central line, right? If we do not, and if that poor IV infiltrates, we will get necrotic tissue, okay? Then we want to go ahead and infuse that area with phentolamine. That's it. I've only had to do it once in my entire nursing career. Okay, so side effects are going to be what we would kind of expect to happen if we're increasing your blood pressure, increasing the workload on the heart. We could see angina, right? Tachycardia, oh, dopamine every single time. And dysrhythmias.
But isn't it like only for a short amount of time? It's tachycardic, like it kind of wears off pretty quick if you push it.
Dopamine is usually a drip. All of the others, if you use IV push, it will wear off after a period of time. Yeah. It should, absolutely. If we're on a drip, though, because your patient is hypotensive and in shock or septic or something like that, we do need to watch for that for some of them. Some of them more so than others. How am I doing on time? We have like a whole hour left. Right. Our HMG CoA reductase inhibitors. You're never going to hear me call it that because I can't pronounce that. Okay. Let's keep it real. All right. So they're going to decrease total cholesterol. They're going to decrease your LDL. They might improve your HDL a smidge. Okay. Do they have to know cholesterol levels and things like that for Hep C? Is that in your list of labs?
Probably.
Yeah. So, all right. Again, used for hyperlipidemia, meaning all of them are elevated. Dyslipidemia, meaning your LDL's too high and your HDL's too low. And hypercholesterolemia, again, your total cholesterol too high. Going to decrease your risk of coronary artery disease and stroke. These are good medications. Anybody who has diabetes already has a double whammy. They should probably be on a statin if they can tolerate it. All right. We want to take these in the evening. Why?
Your body slows down. Is it like something with your liver?
I forgot. Your liver.
I did the discussion question.
Do you guys remember your liver? Yeah, go ahead.
Like normal cholesterol and produced at night.
Your liver is producing its own cholesterol, and it's going to produce more so at night. Okay. So again, keep in mind, we could have people with poor cholesterol and do not eat meat whatsoever. I have a couple of vegans who are on statins in my practice. Okay, because guess what? 10,000 years ago, when we ate once a week, those people who had their liver produce more cholesterol, they lived on. We have Burger King on every corner. We don't need to produce our own cholesterol anymore. Nobody told our body that. So for the most part, again, these are going to be our statins, our torvastatin, our simvastatin, our roomvastatin. I thought that was right. Roomvastatin, Crestor. What else do we need to know? What are our side effects here? Let me start with
Muscle ache.
Yay! Definitely muscle aches is the big one. Okay, that's huge. What else? Do we need to watch kidney function or liver function? Liver function. Awesome. We need to watch our liver function. What was that? Flushing. Oh, what's he thinking of flushing? No, he's thinking of niacin. Holy cow, if you take niacin, everybody go home and do it for fun. It is effective, actually, at reducing total cholesterol. Believe it or not, it is. The thing of it is the side effects of the flushing is so bad that nobody can tolerate it. You want to take niacin? No, she's like, I just wanted the chocolate. All right, so pregnancy category. X. You know, if I'm asking it, it's not going to be an A, right? Again, unfortunately, we got rid of pregnancy categories at the very end of 2015. That makes me very, very sad. They're going to be completely phased out by 2018. It might still be useful for you to remember them, just for a little bit.
Why are they getting rid of them?
They got rid of them because it was not crystal clear. It added liability to the pharmaceuticals. Instead, they replaced it with narratives. And I can tell you as a prescriber, sometimes it's pretty hard. The narratives will say, in essence, make sure that benefits outweigh risks. You know, I mean,
Yeah.
it'll literally tell me if fetal toxicity has happened, if fetal toxicity has happened in animals, you know. But again, there's not big studies on pregnant women. Nobody's going to do a study on a pregnant woman if you're a pharmaceutical. There's not a chance. You know, even pediatrics, same thing. That's why, again, most of our data was generated for a 150-pound or 175-pound male. Nobody's going to touch females in their 20s, right? What else? What's your first line? If you have hyperlipidemia or dyslipidemia, what's first line?
Control diet.
Awesome. Diet and exercise. Okay. Second line, then we're going to go ahead and start a statin type therapy. We do not necessarily want to use our statins for patients with gallbladder disease. All right, so side effects, I think you guys had them all. Muscle pain, nausea, GI disturbances. GI disturbances can sometimes be significant. The muscle aches, sometimes the patients get over them, sometimes they don't. Okay, headache, rash, elevated LFTs. So that's your AST, your ALT, maybe your ALPOS, okay? Do I need to give you plus breaks?
How are you guys feeling? You want a little 5-minute break, or you want a
Let's take a break.
Okay.
I'm going to cut out number 1 and we'll start up with number 2.
years, I've built stamina for this.